Welcome to the Twin Sister Docs podcast. I am Dr. Delana Wardlaw, board-certified family medicine physician, and I am Dr. Elena McDonald, board-certified general pediatrician. Thank you to all of our previous viewers and listeners, and we would like to welcome any new viewers and listeners. Today, we're going to discuss cancer awareness and prevention. Dr. Wardlaw, let's start with breast cancer. Yeah, and there are quite a few cancers we're going to discuss because cancer is on the minds of everyone. Breast cancer. Unfortunately, 1 in 8 women in the United States will receive a diagnosis of breast cancer on an annual basis. Men can get breast cancer too, but far less. We do know that Richard Roundtree, everybody knows him as Shaft, he was diagnosed with breast cancer. So men can get it as well. However, breast cancer, we know that there are certain things that can put you at higher risk for breast cancer. One, family history. If a first-degree relative, your mother, your sister, your children have breast cancer. 2, if you are a smoker. If you smoke, please stop. Yes. If you smoke, please stop. Smoking puts you at risk for breast cancer, high risk for breast cancer. If you have a menstrual cycle for longer periods of time, meaning you start your menses early and or you go into menopause later, you have a menstrual cycle for extended periods of time, then that could put you at higher risk as well. People who have had radiation to their chest previous radiation to their chest can put them at higher risk as well. So if someone's had radiation for a different cancer, yes, for a particular reason, that could put them at risk for developing breast cancer later. Yes. Okay. Yes. And so those are some of the risk factors that can put you at higher risk. Now, there are some things we can control and some things we can't. We can't control our biological sex, and we can't control our age, and we can't control family history. We cannot control family history. But it's important that you know your family history. As sure you should be having those conversations with your family. But there are things that we can control. Things such as not smoking, healthy diet, exercise, and making sure that we see our doctors on a regular basis so that we can get our routine preventive screenings so that we can diagnose breast cancer early. So let's talk about the preventive screenings, Dr. Wardlaw. What are the best screenings for breast cancer? 1, you should be familiar with your breast. That's not an actual screening, but you should be familiar with your breast because if you feel something different, then you can bring it to your doctor's attention. And that's important because you may see your doctor in January for an annual visit. But if you feel something in your breast in March, then you need to call your doctor at that point in time to say, hey, I noticed a change in my body. If you don't notice a change, you can go a whole entire year before you see your doctor again for your annual visit. That is why it's so important for you to know your body so that you can recognize the changes. Yes. So become familiar with your breast. So you can have that conversation. Dr. Wardlaw, in addition to knowing your own body, what else should we be doing to make sure that we are detecting breast cancer at an early stage? Well, also when you go to your doctor's office, for your physical exam and or your GYN exam, a breast exam can be included as well, particularly if you're having an issue or if your GYN doctor decides that they're going to include the breast exam. And when you say breast exam, that's when they use their hands to examine you to detect for any unusual masses in your breast. Yes. Outside of your doctor doing their physical exam on you, what is the next step that can be done? The mammogram. So you go over what happens when you get a mammogram done. So a mammogram, and you should be having a conversation with your doctor as to when you should start your mammogram screening. In general, I usually start screening my patients around the age of 40, particularly African-American patients, because they have a higher risk of dying from breast cancer. So in general, Dr. Wardlaw, women are getting their mammograms at 40 years of age. However, there can be other factors that is individual specific that can dictate whether or not you have to get a mammogram sooner. Sooner, yes, and or if you have to get it done annually or biannually, depending upon your age, your risk factors. So again, it all boils down to you have to have a direct conversation with your physician. And now when you go to do the mammogram, again, yes, you have to get your breast squeezed for about 10 seconds. It's not a pleasant test. It's not a pleasant test. But it's very short. Yes. It's very brief. You can hold your breath for 10 seconds and it's over. So we want to make sure that that does not deter you, because the purpose of the mammogram is to detect the cancer before you can feel anything on you doing a self-exam or your physician doing an exam. So it's very important that you get this screening test. And that's why it's called a screening test, because it's done, recommended at a specific age or at around an age, certain ages, before you can even feel a symptom, or even before symptoms develop, or even before a physical finding is found on the physical exam. So a mammogram is a screening test for most people. And the screening test is based on age. We're not waiting for symptoms to arise. Yes. Screening test so that we can detect it at the earliest phase possible so that you can have the best outcome with treatment. Yes. Now, you can also, a mammogram can be a diagnostic test once if you feel a lump or pain in your breast, or if your doctor feels a lump on examination or something abnormal on examination, then it can become a diagnostic test. So the point of the matter is, we're not waiting for you to feel a lump or notice a difference once you get to a certain age. But if you do feel it, yes, then that's an indication to get the test before it's recommended by the guidelines. Yes, you may have to get it done sooner. Absolutely. So again, this mammogram test, I have had a mammogram. I've had a mammogram multiple times. Yes, it's uncomfortable, trying to figure out, hopefully there will come a better way to do it. But until then, we just have to really grin and bear it for those 10 or 15 seconds, as Dr. Wardlaw discussed, because it could be the difference between detecting cancer early and saving one's life. Now, the mammogram can be the initial study, but then you may have to follow up with an ultrasound. You may have to follow up with an MRI, or you may have to follow up with a biopsy to get an actual tissue diagnosis to actually confirm if it is a cancer or not. So when they do the biopsy, they actually go in and take a piece of the tissue that they're concerned about to see if it's actually cancer or not. Yes. And so it could be you can go get your mammogram, or you could be done and they say, come back in a year. Or they can say, well, no, we have to follow this up in 6 months, or no, we have to get an ultrasound now so we can get a further evaluation or a better look at the area going on there. So it could be a multi-step process, or it could be a single-step process. Right. But you should absolutely get it done. There should not be a deterrence there. This breast cancer is near and dear to our heart, because our maternal grandmother died of breast cancer at a very, very young age. And if she had had an opportunity to get it done diagnosed earlier, she may have lived an additional 30 years. She died at the age of 53. So when we talk about getting these tests done, want to make sure that people have access to get the tests done, and want to make sure that people are aware so they can have a discussion with their doctor about when they should be getting these tests done. Yes. And we know that sometimes access to care is not always equal. People are underinsured. People don't have any insurance at all. You can contact, there are various hospitals that do mammograms during certain times of the year where you don't have to have insurance. You can get your mammogram done. Sometimes you'll see a mammogram van out in the community at community events. So if you see that advertised, you really want to make an effort to contact the number or whoever organizing the event, so that you can have the opportunity to get that mammogram done if you are lacking insurance and having difficulty getting it done another way. The data shows that Caucasian women are diagnosed at a higher rate for breast cancer, but African American women are dying at a higher rate from breast cancer. Can you go over that? Why we're seeing that? Well, yes, African Americans have the highest mortality or death than any other ethnic group for breast cancer. And there are a variety of reasons for that. One is lack of access to care, where we're not getting diagnosed in a timely manner, and or we are getting lost to follow up where the diagnosis may occur, but we may not receive the follow up, whether that is due to not being able to get to the doctors, not having a doctor. So that can contribute to it as well. And also, African American women have a higher rate of a triple negative breast cancer, which does have a higher rate of leading to death for African American women. So that triple negative diagnosis leads to a poor prognosis or outcome. Yes, particularly if it's not diagnosed in a timely manner. Okay. So want to make sure that we are getting our mammograms. We're not waiting for symptoms. Once you get to a certain age, make sure you're talking with your doctor, because there may be other indications that may determine if you need to get a mammogram at a sooner time. But the key thing is make sure that we're getting the mammogram so that we're being diagnosed early and we're being treated earlier to have a favorable outcome. Yes. Now, after we discuss breast cancer, Dr. Wardlaw, let's discuss colon cancer. Colon cancer is a cancer that we have an advantage on because we can diagnose colon cancer at one early stages and or at precancerous stages. Now let's go back and talk about what that means. Colon cancer is colon of the large intestine. Let's just clarify that first. And so in the colon cancers start out as polyps. And when a polyp develops, if we have the opportunity to diagnose that polyp and remove it before it can grow into a cancer, we have prevented colon cancer. Colon cancer is preventable. So how do we prevent colon cancer, Dr. Wardlaw? We get colonoscopies. Okay, and so let's talk about the dreaded colonoscopy. And after this conversation, we want to make sure that it's not dreaded. Exactly. And so the issue that most people don't like about the colonoscopy is the prep, which we'll get to in a minute. But when you do a colonoscopy, your colon is approximately 6 feet long. And when they do the colonoscopy, they use a flexible tube that has a light and a camera attached to it that they insert through your rectum and advance it through your colon from one end to the next. And they're looking to identify anything that looks abnormal, any inflammation. Because not only were they looking for colon cancer, they're looking for inflammation of the colon, conditions like Crohn's disease, ulcerative colitis disease. They're looking for polyps. Polyps are those precancerous growths that can potentially turn into cancer. Now, not every polyp will turn into a cancer, but we don't know that. The doctor doesn't know that when he or she goes in. So you remove any polyp that you see. Remove any polyp that you see, right, and send it off to the lab so it can be analyzed. But at that point, you have prevented it from potentially growing into a cancer. Key. Now, unfortunately, sometimes you get in and get your colonoscopy done, patients get it done, and there's already a cancer sitting there. However, if it's caught at its earliest stage, meaning that it is just within the walls of the colon itself and hasn't spread to any other areas, then there's a higher chance of survival, of beating that cancer. So this is why the colonoscopy is key. One, it could be a preventive test, right? Preventive meaning a preventive screening test, meaning that we recommend this test at a certain age. And the age is 45 now. It used to be 50 for many years, but we have noticed over the last several years that the age is getting younger. The age is getting younger and younger for colon cancer. So the recommendation now is 45, whether you're black, white, orange, yellow, purple, or green. You need to get a colonoscopy. And again, to 45. Colonoscopy is a screening test. We are not waiting for you to have symptoms. You're 45, that means you should be getting your colonoscopy. But also, if you are 35 and you are having symptoms that are concerning, then you could be sent for a colonoscopy. That's no longer screening. That's what Dr. Wardlaw refers to as diagnostic, because now we're actually looking to see why you're having particular symptoms. Yes, so if you're having symptoms such as rectal bleeding, unexplained weight loss, unexplained abdominal pain, unexplained, if you're having black stool. So these are reasons for you to be, one, talk to your doctor. And if you're 30 years old and those symptoms are occurring, then a colonoscopy can very well be recommended at that time as well. So, because at that time it's not screening, now that it's diagnostic. And here's the other beauty of the colonoscopy. Now we've gone from screening to diagnostic to therapeutic. Why is it therapeutic? It means that a therapy can be completed right there during the colonoscopy. The polyps can be taken out. So once the polyp is removed, that's therapeutic because they're now gone. They're gone. Yes. So no opportunity to develop into cancer at that time. Yes. Now the polyps can grow back. So it doesn't mean that a colonoscopy is one and done. So if you go in and you don't have any polyps, then the doctor will typically say, hey, we'll see you in 10 years. We all want that. We all want that when they wake us up from the colonoscopy. Your colon is clean. We'll see you in 10 years. And that could vary too whether or not if you have a family history or not. But again, in general, 10 years if your colon is clean. If you go in and there's a polyp that is removed, depending upon the type of polyp that is removed, you could be back in a year, depending upon the type and the number of polyps. So if you have multiple polyps or the type of polyp, you can hear something called a tubular adenoma or a serrated polyp or a tubulovillous adenoma. Those things will require you to be back sooner. Yes. Okay. So the time that you're required to come back could be anywhere from 10 years to 1 year. Now, if there's something that's seen on the colonoscopy, diagnosed on the colonoscopy, unfortunately, if the doctor gets in and there's a cancer, then of course that has to be addressed immediately. And so then other treatments may follow that. Yes. Or sometimes you get in and you have polyps that were seen or some abnormalities that were seen. The doctor may say, hey, I need to see you back in 6 months. Right. Now, here's the key thing. In order for the doctor to see what's going on in your colon, it has to be clean. It has to be clean. The colon's job is to store feces. And so on any given day, it's going to be sitting there. You're going to have feces in your colon. So it absolutely has to be clean. Please listen to me. If you go to your colonoscopy and you do not follow the prep instructions and you get there and they see feces there, you will be sent home. And they will abort the exam. Or if they ask you and talk to you and say, hey, did you finish your prep? You may not even make it to the colonoscopy room itself, because they're based on the answers that you give, there's a good chance that you won't be clean. And that makes the test not effective at all. So I say to you, please complete the colonoscopy prep. Now let's talk about this prep, because the prep is a beast. I have done the prep. Dr. Warlaw has done the prep. But it is necessary in order for us to get this necessary test. So Dr. Warlaw, when we go over prep, what do we need to do? Dr. Warlaw is pulling out what you need to do in order to have a clean colon to get this colonoscopy done. Now, first off, you have to go on a liquid diet the day before the test. Yes. And when we say liquid, we mean a clear liquid diet, meaning when you look through the glass, you have to be able to see your hand on the other side. So you can't have smoothies. You can't have blended down drinks. So you have to be able to see clear to the other side. So that's water, that's apple juice, that's a lime Gatorade, right? So you got to be able to see clear to the other side. And you have to be on that liquid diet all day. And then 2, you have to do prep. Yes. There's no getting around it. Yes. And so the prep, so many people hear about, oh, I have to drink this big gallon of solution. Oh, I just can't do it. Yes, you can. Yes, you can. Yes, you can. And you can and you will. And I've had colonoscopy, and this is the prep that I had to use a prep similar to this. Yeah. And the prep contains these 2 packets of powder that you take the powder here. This is a powder pack, and you will empty that into this bottle here, right? And so you'll add put the powder in, you'll fill water, you'll fill it up to the fill line, right? And then what you do is every 15 minutes, you will pour this into a cup, an 8-ounce glass, and you will drink this solution, right? And so you generally start this the evening of the colonoscopy. You want to make sure you're home, because guess what? It's going to cause you to run to the bathroom. Right. So you can't be out, you can't be at work, you can't be out shopping at the grocery store. Right. And this isn't that bad. You can get through this. You can get through this container. And the key thing is that the preps may have different, the containers may look different, the packets may look different. You must follow the instructions that your doctor gives you.
Yes.
Don't talk about what your friends did. Don't talk about what your husband did or your wife did or your mother did. Follow the specific instructions that your doctor gives you. When I did my prep, I read all the instructions, went to work. Went to work that day because I didn't want to be home, going in and out of the kitchen. Came home that evening, I mixed my prep the way I was supposed to, set up all of my glasses and set a timer. And every time that timer went off, I went in and drank another glass of the prep. But I was also going to the bathroom. Once it kicked in, I was going to the bathroom. So you must prepare yourself to do the prep because, to Dr. Wardlaw's point, you want to have the cleanest colon possible, because the worst thing to do is you prep for the day before. You do everything you're supposed to do, or you miss some steps, and the doctor says, Mr. or Mrs. So-and-so, I cannot see your colon. There's too much feces or poop in there. You're going to have to go home and do it another day.
You definitely don't want to do that.
You do not want to do that. So please follow the instructions to the T. And then once you get to the colonoscopy, that is the best sleep ever. When they took me into the room, they said, after they asked their screening questions, they checked my vitals, make sure everything was okay. They put that IV in, and the next thing I remember was being awakened by the doctor that says, the doctor and the nurse said everything went well. So that's what you want.
Yes, and the colonoscopy. So when you get there, you get to the colonoscopy suite. You'll meet the nurses. They'll do your vital signs. The anesthesiologist will come in and talk to you and tell you how they're going to give you this medication they're going to put through the IV that will, the procedure itself, you will not remember at all. You will not remember the procedure. But so the challenging aspect is the prep. And this is just an example of one prep, as Dr. McDonald says. So you have to follow the exact instructions that your doctor gives you. This prep right here, it was a split prep. I did a full container the night before, and then I woke up the morning of the procedure, and then I did another container. But again, this is just the example of one prep, but I just want people to know that it's not that bad. It's not that bad, and you absolutely need to get it done. Colon cancer is a preventable cancer. We all know we unfortunately lost the late, great Chadwick Boseman, also known as Black Panther, at the age of 43 to colon cancer. So we do want to make sure that we are
getting properly screened.
And so that means going to your doctor, getting a recommendation, getting a referral so that you can get the procedure done. Now, colonoscopy is our best test for being able to detect polyps, remove them, if there's anything suspicious going on in the colon, taking a biopsy of it, getting a definitive diagnosis. The colonoscopy is the best test to do all of those things, or the gold standard, what we call the gold standard. However, put that away from me, Dr. McDonald, there are some people who may not be able to get the colonoscopy, depending upon if they have some medical conditions that may prevent them from getting a colonoscopy. You need an escort to get you home from the procedure because you received that medication that gives you that good sleep. You will need an escort. They don't let you do ride shares. You have to make sure that there's somebody who you know personally who's going to make sure that you can get home safely. Sometimes that can be an issue for people. So if you cannot get the colonoscopy for any reason, have a conversation with the doctor to see if there are any other options. And there are some options that are available. And with that being said, we have here, there is the Cologuard. And you may have seen this familiar box where the Cologuard is you actually do a stool test at home, where the stool is checking for blood or any changes in the DNA and the stool. And so again, you take this. This is the toilet bracket. You lift your toilet seat up, put it on the toilet, put the toilet seat down, and then I'm just gonna put this around here. You sit this You take the top off, and you sit this in the bracket, right? So this is in the bracket. Your toilet seat is down, right?
And this
now
is on the toilet.
And so you sit down and you have a bowel movement. And then after you have the bowel movement, you take this probe here and you take it out and you just wipe it across take a couple strokes across the bowel movement, okay?
And you wipe it across the poop.
Yes, you wipe it across the poop. And then you put the probe back into its container here. And then this right here is the preservative. You pour this into the container, and then close it and seal it up. There will be labels. That is what Dr. McDonald is holding. You'll have labels to label your specimens, and then you package it up and you send it back. You have options. You can either take it to a mailing center to have it send it back. UPS, you can have UPS pick it up for you. Do not take it back to your doctor's office.
They can't process
Do
it.
not take it back to your doctor's office. It has to be sent to the lab. And so this is another way to check for, we'll clean this up later,
It's another way to screen for
colon
cancer.
cancer. Now, that test right there, if you are having symptoms, if you're having rectal bleeding, if you're having unexplained weight loss, if you're having unexplained abdominal pain, then
That's not the test for
that's
you.
not the test for you. You need to have a colonoscopy, or if you have a family history, or if you've had previous polyps, then typically that is not the test for you. Again, have a conversation with your doctor.
Right.
But typically that is a screening test because you've turned the age of 45. You don't have any symptoms, family history, things of that nature. So that test would be an option for you. Again,
Please, please, please follow the instructions.
yes.
Whatever instructions are there, make sure you follow them, because if there's a misstep, then it may mess up the testing.
And when I prescribe this for my patients, there's a handout that comes along with it. There's a QR code that connects you right to a video. You can look at the video, and it takes you step by step. Okay, and so again, that is the next option that you have. Again, it's not therapeutic. I mean, you can't see exactly what's going on in there. It is a true screening test. Now,
What happens if that test comes back positive or abnormal, doctor?
now you're assigned up for a colonoscopy.
Okay. So you may end up getting a colonoscopy one way or another.
Now you're assigned up for a colonoscopy. Now, remember we talked about the colonoscopy. If your colonoscopy was clean, you don't have to get another one for 10 years on average. Again, conversation with your doctor. But this Cologuard test has to be done every 3 years.
Okay.
Okay? Every 3 years.
All right.
All right?
So colon cancer, a preventable disease, a preventable condition. So please have a conversation with your doctor. If you are 45, you should be bringing this up to your doctor. But very, very, very important screening test.
One last thing, there's another screening test as well. So we talked about the colonoscopy, we talked about Cologuard. Then this is a fit kit where this also checks for stool, checks for changes, blood in the stool or changes in the DNA in the stool that could indicate that there is, possibly a polyp or cancer there. So again, this test has to repeat it every year. If it's done, this is also done at home. Again, I'm just going to do quickly where you do a sample at home. You basically put this biodegradable paper in your toilet. You have a bowel movement, and then you take the swab and
You swab
get
the
the yep, swab the poop, and then you label it, and then you put it in the mail, and the test is analyzed. If this test comes back positive, you have to get a colonoscopy, and you have to do this every year. Again, so colonoscopy is the best option, but these are some other options as well that you may have if you're unable to get a colonoscopy, if you're unable to do the prep because your job doesn't allow you to have additional days off, or it's some issue you can't do that, or you can't get a ride home.
So you do have options.
You do have options.
You do have options. And with that being said, let's move on to prostate cancer, Dr.
Yes.
Wardlaw.
Now, prostate cancer is a
What is the prostate? Let's start there.
Prostate is a small walnut-sized organ in the pelvic area of the body. It's just between the bladder and the rectum. Hence why the rectal exam is
So
the way that
important.
the way that the prostate is checked. It's the biological males have a prostate. Biological women do not have a prostate, and the prostate is another organ that can develop prostate cancer. And many times prostate cancers are very slow growing. Not every prostate cancer is going to need treatment right away, depending upon, what your stage is and what the level of the prostate is, what the grade of the prostate is. Again, have a conversation with your doctor, your urologist. The urologist is the
specialist.
The specialist, as you're referred to evaluate your prostate cancer. And then if there's a cancer noted, you may have to see the cancer doctor, the oncologist. But
how do we examine the prostate?
So the prostate one, there are a couple of ways. One, the direct exam of the prostate is the rectal exam itself. Many people cringe. Oh, I don't want that exam done. But I will tell you, the rectal exam takes approximately 5 seconds max, if that long. Prostate cancer does not respect anybody's pride. So if you get prostate cancer, guess what? It'll be more than a 5-minute digital rectal exam where the 5 second. I'm sorry, not minute. 5 second rectal exam where the doctor does have to put his or her finger in your rectum to feel the prostate. Is it big? Is it soft? Is it swollen? Is it tender? So those are all indicators that something is going on with the prostate. Now, there's the prostate blood test, the PSA blood test that is done to you're looking to detect the level to see if the level is getting higher than what it should be. The elevated PSA does not necessarily mean that it's cancer. It could be a big prostate. It could be a swollen prostate. It could be an inflamed prostate. It could be an infected prostate. But it could indicate prostate cancer. And then you have to, again, see the urologist, have further evaluations.
To determine the next steps.
Yes. But to get a definitive answer for if it's prostate cancer, a biopsy would be involved. It is discussed to get a definitive tissue diagnosis and say, yes, this is clearly prostate cancer, and then determine what the next steps would be. And again, that the next step could be what we call careful monitoring or aggressive surveillance, where you're monitored every so often. You get your labs checked, you get MRIs, you get scans, you get imaging done, or it could be a prostate surgery where the prostate is removed. So, and then it could also involve, whether it's radiation treatment, whether it's, particular treatment to the cancer itself. So all those things, of course, will have to be determined. But key, prostate cancer is very common, and it's more common in African-American males.
Okay.
And so we have to make sure that we are absolutely getting our prostate screening. Again, I hear it all the time in my office. I don't want to do this. I don't want to do that. I was going to remind you, some things we have to do. Prostate cancer does not respect anybody's pride. And so you have to make sure that you are doing the recommended screenings, okay?
All right. So thank you for joining the Twin Sister Docs podcast today as we discuss cancer awareness and prevention. On our next episode, we will continue further discussion of cancer awareness and prevention.